Cardiac MRI, or magnetic resonance imaging, provides superb images without exposing the patient to radiation. It's used to help diagnose heart disease, heart valve problems, coronary artery disease, heart tumors, and disorders of the pericardium. On this week's Health Talk, an expert in cardiology and cardiac MRI will join us to discuss the benefits of cardiac MRI. This procedure is useful for patients and for their doctors. So stay tuned for today's Health Talk. We're up next. Hello, I'm Dr. Eric Mazer. Today's Health Talk topic is the benefit of cardiac MRI procedures. Joining me is Dr. Joseph Burdowski, a cardiologist with Nuvance Health. He's the Nuvance Health physician practice. So Joseph, again, welcome to Health Talk. I know you're new to Nuvance, you're new to the Norwalk area. Great to have you here. You're a cardiologist with specialty in MRI, so that's a lot of training. You've got internal medicine training, you do cardiology training, and now you've did a couple of years in MRI. Tell us about how that interested you and what is it? It's actually, frankly, a new specialty since I was practicing.
Yeah, so thank you very much for having me on the show. I certainly appreciate being here and starting work at Nuvance. So I actually joined the hospital a couple months ago. So the training, it's the general training you mentioned, medical school, internal medicine residency, and I always knew I wanted to be a cardiologist, so I did a 3-year subspecialty in that. And as I was getting close to finishing up, I was very interested in cardiac imaging, also cardiac prevention, and really just how we can learn to diagnose all of these disorders much better. And so at the end of my training, I decided to do an extra year of additional subspecialty training in advanced cardiac imaging, and the emphasis was on cardiac MRI as well as cardiac CT.
And MRI is a fascinating imaging modality. Maybe you could say a few words about it, because it really gives a remarkable image of soft tissues and soft tissue planes within the body. I'm sort of amazed at some of the images we can get.
Right, and technology is getting so much better these days, so the image quality is continually improving. But basically we use a combination of radio waves and magnetic fields to generate pictures of the heart. And for cardiology especially, a picture's worth 1,000 words in a sense. Not only do we get still pictures, looking at the heart muscle, the various tissue properties, but we also can get live images looking at almost movies, or what we call cines, of the heart, almost in action. And we see the valves opening and closing and looking at cardiac function.
It's real. I can't emphasize to people at home how remarkable these images can be from an MRI. The physics is pretty complicated. It has to do with spins of electrons and strong magnets. And the machine, I must say, I've had a couple of MRIs of my back. I feel like I'm inside a pile driver. It's just, it makes horrible, loud noise. It sounds like the machine's going to fall apart. And for such a sophisticated machine, it's very noisy. But that being said, this is without radiation. We get to see inside the tissues and actually can see some details you can't see on an X-ray or even on a CT.
Correct. The level of detail is certainly great. I mean, the machines have gotten a little bit better over time. The main drawback is it is a long, narrow tunnel. The bore has increased in size, but still patients with claustrophobia have a tough time with it. And the test can be as long as an hour, which can be a limitation. But I mean, most patients do great with the test. We certainly work with them very closely. And again, that image quality is just fantastic. There really is no replacement for MRI. Traditionally, as cardiologists, we've been using ultrasound echocardiography, which is still our first-line test. But the level of detail with these more advanced testing is just fantastic, and it really helps out patients.
Well, tell me, give me an example of what are the kinds of things that you can see on the MRI that you might not see on an echo, and how is it useful? Even giving some diseases that you find it useful to diagnose.
Sure. So the most common reason for a referral is patients with cardiomyopathy or a weakened heart muscle, or if they develop heart failure. And usually the echocardiogram may show a reduction in the heart function. And the reason for the MRI after the initial medical workup is to really look for causes. If it's not a blocked artery, maybe it's some other process. Maybe it's something called myocarditis, which is inflammation of the heart muscle. Or even if there's a blockage that wasn't seen on other testing, sometimes we can show or see signs of scarring in the heart. I would say the most important aspect of it is it's really considered the gold standard for assessing cardiac function and really assess that ejection fraction or how much the heart's pumping out more so than any other
I'm used to
test.
using the echo, which basically would show the heart muscle crudely in diastole when it's filled and then systole when it's maximum pumping, and that difference you'd say it has an ejection fraction of 60% or something like that. Do you get actually even more accurate ejection fractions with an MRI?
Correct. So traditionally with echo, a lot of it can be visual estimation. We do some measurements with echo as well. You can do three-dimensional echo too to get more numbers. But with MRI, we give an exact number down to the decimal point of what the cardiac function is. And a lot of it's manipulation and something called post-processing, where I'm sitting at our workstation taking these measurements, drawing circles of the heart to really see how much it's contracting and to get that exact number.
So you can see subtle wall motion abnormalities?
Correct.
As well. Now, you mentioned looking at the causes of cardiomyopathy. Interesting. I just did a session with the University of Connecticut medical students on amyloid. So that's high in my mind. People at home may not know what that is. It's a fairly uncommon disease where there's waste protein laid down in the body tissues, and some of those amyloid diseases affect the heart disproportionately and cause it to pump poorly. Can you see, does that have a distinctive picture on MRI? And does that allow you to make a definitive diagnosis even without a biopsy?
Yeah, so MRI is getting much better at that, and we can make a pretty clear diagnosis. Still, the gold standard is probably biopsy at this point, but there's a couple different types of amyloid, and cardiac MRI is very good at diagnosing them. We can see differences in some of the properties, what we call T1 properties of the tissue in the heart, and those are substantially elevated in a lot of disorders, but in amyloid, they're through the roof. They're extraordinarily high. And oftentimes we get plenty of referrals for that. And what's interesting as well, we can track these numbers. MRI is a lot about not only looking at things and qualitatively assessing, but getting numbers and quantitatively kind of tracking things over time.
Well, so you may get an idea of how much infiltration there is by this abnormal protein and see it progress over time?
Correct.
So you're not just looking at functional changes, but actually what would be the image, the image itself would change.
Yeah, looking at those properties of the tissue, yeah.
That's really amazing. So what, again, I can think of a number of reasons for cardiomyopathies. Are you able to differentiate most of them based on the cardiac MRI? You know, I think of postpartum cardiomyopathy. I guess sarcoid, you can have a cardiomyopathy, and you said ischemia, post-viral. You know, are you able to separate these by looking at the heart by MRI?
So some of them, yes. Sarcoid has a distinctive pattern after giving contrast. You get kind of contrast settling into certain areas of the heart. Same thing with myocarditis or inflammation. Things like postpartum cardiomyopathy or dilated cardiomyopathies. Oftentimes we don't see a lot of that enhancement, but if we do, it's an indication that there's fibrosis or abnormal tissue and can indicate more advanced disease in certain patients.
Now, going back to the most common cardiac disease, coronary artery disease, which is atherosclerosis, which is a hardening of the arteries going to the heart. Does the MRI offer you advantages with that particular group of patients?
So it can. So one thing that we do some is we don't do stress tests here at Nuvance with MRI, but a lot of centers around the nation and world are starting to do stress MRIs. At the present moment, what we're doing is we can inject the contrast and see how it lights up the muscle and see if there's any mismatch in terms of blood flow, but that's just at rest, not stress. But we can see if there is a scar, which can indicate that you've had a prior heart attack, and we can quantitate how much there is.
Now, I know one of the things is with conventional catheterization, you stick a catheter, a needle, and a tube up through the leg or the arm. Cardiologist gets it into the appropriate vessel in the heart, and then you squirt some dye in, and they take pictures. I'm going to get to some place that means sets. Normally, they will measure two-dimensionally the width of the chamber of the vessel, the diameter of the vessel. And they'll say, well, they've got a 50% or a 70% or a 90% stenosis, and oftentimes therapy is based on that. One of the shortcomings, as I understand it, please correct me, you're a cardiologist, is that this is largely a two-dimensional view you get of the artery. And you just mentioned that the MRI can give you a three-dimensional view of tissues. Is it helpful in looking at specific coronary artery lesions because you've got that three-dimensional view, or are they too small to be discerned by the MRI?
So there is some interesting research in looking at the coronary arteries with MRI. They are a bit small and with a lot of cardiac motion. The heart's always beating in the body, so it's really hard to get a nice still picture of those arteries, especially with MRI. There are new sequences where you can look at them, not in the same detail to see distinct blockages with most scanners at the present moment, but you can see some of the proximal arteries a little clearly. Looking for anything called anomalous coronary arteries, we can see that branching pattern. But the gold standard, if not for catheters, not catheterization, then it's probably a coronary CTA.
Okay. Where the dye is more conventional dye, not the
Correct,
MRI
but still
dye.
not invasive, yeah.
So you said patients, which patients should I be referring then for a cardiac MRI? You mentioned cardiomyopathy, which means a weakened heart muscle. So somebody who's got congestive heart failure, somebody who on echocardiogram, which is an easily available test, shows a decreased ejection fraction, heart's not squeezing hard enough. Is that the large majority of patients that you get, or are there other, you mentioned valvular disease and others. Tell us a little bit about how that helps you in those other circumstances.
Yeah, so valve disease is another one. If you have mitral regurgitation that's approaching severe aortic stenosis, aortic regurgitation, leakiness to a lot of those valves, we can quantify how much leakiness there is, look for changes in the heart muscle as well. Another big reason is hypertrophic cardiomyopathy, a genetic condition that can affect young or even middle-aged people and can contribute to sudden cardiac death. And referring those patients is important because we can get a close look at the heart and look for any abnormal tissue, fibrosis, or scar tissue that can predispose someone to cardiac events.
Would you say, of the world of patients cardiologists see, is this a relatively small proportion that need an MRI, or are we seeing the indications grow so more and more patients will end up getting this?
I think what we're seeing now is the indications are growing. There's been more appropriate use criteria or guidelines from our societies really expanding on some of the uses and when it's appropriate to order these tests. So I think it is growing, and I think there is an increased need for more cardiologists and radiologists to get involved in cardiac MRI to make it more accessible.
Well, this is really, really interesting, because this again is the next sort of technical leap forward, which is really kind of astounding with cardiac imaging in and of themselves. We've got just a few seconds left, but could you say a little bit about how the MRI machine captures static images with the heart actively beating? And just for people to know at home, when the heart's beating, it's moving around. So it's hard to take a picture of something that's moving so fast. Go ahead.
Yeah, so most of our sequences are done with the patient holding their breath, so they may have to hold their breath for anywhere from 8 seconds to sometimes 20 seconds, depending on what we're seeing. And for some sequences, we take a quick picture when the heart's in a relaxed state, and we do that over several different heartbeats to try to reconstruct a still image. Other moving images, we acquire the information from the heart from the entire cycle of the heart. And it's over several different heartbeats to really accumulate that information, merge it into one movie.
And again, what's so amazing is the computer can do this mathematically for you. It can show it as an image. It's truly astounding. And we've run out of time. I mean, this is just an interesting new area I think that people should be aware of and can potentially be very, very important to know about. Unfortunately, we have run out of time. I'd like to thank my guest, Dr. Joseph Burdowski, for joining me on Health Talk today, and thank you for watching. Remember to share your questions and comments with us by contacting us at healthtalk@newvancehealth.org.
Our fight against coronavirus isn't over. We still have to slow the spread and do our part. Let's wear face masks in public. Stay 6 feet or more from others. Follow state and local guidelines. Wash our hands frequently and stay home when we feel safe. For ourselves, for our loved ones, for our future. Let's move forward together. Learn more at coronavirus.gov.
145 over 92.
180 over 111.
182 over 100. And I had a heart attack and a cardiac arrest, and then a stroke.
Your blood pressure numbers could change your life.
A lot of people don't understand, including myself, I didn't, now I do, the impact of having a stroke.
My memory is shot.
When I woke up, I couldn't speak.
If I would have followed a treatment plan, I would not be in this situation.
It's a tough journey.
Lowering your high blood pressure could save you from a heart attack or stroke. If you've stopped your treatment plan, restart it or talk to your doctor about creating one that works better for you. Start taking the right steps at manageyourbp.org.
It's a new life, but I'm gonna make it better. Coming back. Ask your doctor, check your blood pressure.
Cardiac MRIs are useful in diagnosing a number of cardiac conditions without exposing the patient to radiation. In our upcoming health talk, we'll discuss the science and technology of cardiac MRIs, as well as the patient experience in receiving one. We'll also explain the difference between a cardiac MRI and an EKG or electrocardiogram. My guest is Dr. Joseph Burdowski, a cardiologist with Nuvance Health. Hello, I'm Dr. Eric Mazer. Today's Health Talk topic is how cardiac MRIs work. My guest is Dr. Joseph Burdowski, a cardiologist with Nuvance Health. Joseph, thanks for joining me. Really interesting, cutting-edge area you're involved in, cardiac MRIs. Again, the first MRI I ever heard of was a brain MRI and was blown away by the pictures. But the brain sits there, it's static, you can mobilize the head. The heart's jumping around in the chest and the chest is busy breathing. How can you get a good image of a heart using an MRI? And tell us a little bit about the physics of getting an image of the heart.
Yeah, so for the MRI, we use a combination of radio waves and magnetic fields to manipulate the way the protons spin in different tissues of the body, and they spin at a different rate in different tissues. And so for the cardiac MRI specifically, the heart's always moving, as you mentioned, so we get a nice still picture of it. We have the patients hold their breath during our acquisition, at least from most of our images. It can limit the time, but because our technology is getting better at doing these things faster, the breath holds typically aren't as long as they used to be, and maybe around 8 to 20 seconds.
So we talked about proton spin, and it's really sort of amazing to me. You get exposed, first of all, to say, let's start even, there's no radiation with the MRI. So these are not X-rays that are going to affect your genetic material. They're not going to give you a risk of leukemia, birth defects, none of that sort of stuff, which is in and of itself amazing. So we use a magnet then to set up the molecules, or actually the atoms in the patient's tissues, that then give off a signal that we can measure. Is that what's happening with an MRI?
Correct, exactly. I think you nailed it right on the head. It's really the way the protons spin in the body. Again, different tissues can spin at different rates, and when we apply the magnetic field and then let the protons spin and then relax to their kind of baseline steady state, we measure the energy.
And that energy is not it's not X-ray energy, so it doesn't have that damaging effect.
Correct. There's no radiation with these tests. Again, really just the magnetic fields.
And yet we can measure these energies and produce through, well, the picture is actually produced through mathematical modeling, isn't it? There's never really a picture that comes out. It's a model of the numbers that we get out of these machines, isn't it? Correct.
A lot of it's done with advanced computer modeling, analytics. Some of it even bypasses what I'm capable of understanding, but certainly it does it fairly quickly too. From the time it takes to get the image to when we see a picture pop up, it's really seconds.
And that's truly amazing, and it really shows you how far technology has come, that we're able to use this property of I guess, atoms to produce images that have clinical utility. What's it like for the patient?
So for the patient, it is a typical MRI. Unfortunately, we don't do open MRIs with cardiac studies. It has to be a closed kind of circular bore, almost like a tunnel. And the patients can be in it for 45 minutes up to maybe a little over an hour, depending on the reason why we're doing the study. And we're with them, we're talking to them throughout the test, we're taking them through holding their breath and then breathing normally. So it feels like almost we're right next to them, and we also play music for them to make them more comfortable. So there are ways to help pass the time.
I've had a couple of MRIs for some back issues I've had, and I will say I'm not one that is susceptible to claustrophobia, but you really are pretty enclosed in a fairly tight tunnel. And I think it takes some conscious effort not to become overwhelmed by it. Not that I was ready to run out screaming, but I was happy that when it was over. You did tell me something before the show that I think would be very interesting and very reassuring. Since this is such a new procedure, You're actually there at the MRI, talking to the patient and talking them through it, aren't you?
Yeah, so I'm usually right next to the technologists who are kind of operating the machine. And we're kind of going through it, seeing what we can cut off from the protocol, seeing what we need to add, looking at the images as they come across, because if we see anything serious that we need to image more, I'm always there reviewing things, and we can do everything in one shot.
Do you give the patient the results right after the MRI?
So unfortunately, a lot of it has to go through the physician ordering the test. But since I'm a cardiologist and I actually refer patients for this test, generally afterwards I'll do a quick read and give them some preliminary results.
How did you get interested in this, Joseph?
So in my cardiology training, I was always interested in cardiac imaging, ultrasound, echocardiography, preventive cardiology. And this kind of emerged as something that was definitely curious for me. I was wondering how we can get such great images of the heart, but I also enjoy diagnosing patients and trying to at least find answers where previously we were kind of questioning things.
Maybe you can go through a little bit. What are some of the diagnoses that we can now make with a cardiac MRI that might have been difficult or much more invasive in the past?
Yeah, so one is looking at a condition called cardiomyopathy or heart failure when the heart function is significantly reduced. Another one is myocarditis, looking for myocardial or heart inflammation. Also that lining around the heart called the pericardium, if that gets inflamed, we can see that on MRI. Conditions such as hypertrophic cardiomyopathy, which is a genetic condition that can happen in young patients or middle age. And other rare conditions such as sarcoidosis or amyloidosis are some of the top indications.
So if somebody is having a weakness of the heart muscle that's not explained, that would be a good referral for a cardiac MRI?
Yeah, if we don't have a good reason as far as why the heart muscle is weakened, cardiac MRI is beneficial to rule out other secondary causes, also to get a much better picture of the heart and look for any features that may put the patient at higher risk if there's any evidence of scar or abnormal heart tissue.
Now, I don't want to get too technical for people at home, but I know when we talk about heart failure, we break it up to systolic dysfunction and diastolic dysfunction. One of what that means for people at home is the typical cardiac failure you think of as the heart muscle is weak for one reason or another, and it's not pumping enough blood out, and we call that systolic dysfunction. Diastolic dysfunction is sort of weird if the heart gets stiffer, so it doesn't fill as easily, and therefore you don't pump enough blood, but it's not really due to weakness. Is it useful in diastolic dysfunction?
So in some cases, I would say across the board, it's less useful, at least with current technology. But some patients that have that diastolic dysfunction or stiffening, sometimes it's due to a secondary disorder like amyloidosis. And certainly, diagnosing that, it's important because now we have great treatments for that in certain cases.
Yeah, I know for a while they talked about specific, echo findings, a starry sky or something like that on the ultrasound examination of the heart. Do you have similar kind of characteristic images when the amyloid affects the heart with MRI?
So we do. There's something called the T1 relaxation time, more of a technical term for looking at one of the tissue properties of the heart. When it's elevated substantially, it can indicate amyloidosis and helps us calculate something called the ECV, or extracellular volume, which is a fancy word looking at the space in between the muscles where that abnormal protein is deposited.
So you can get some quantitative idea of how much amyloid is there?
Correct, to a rough extent.
And I know we mentioned that it's useful or is becoming useful to evaluate the valvular heart disease. Can you say a few words about that?
Yeah, so sometimes with ultrasound, we do get a good picture of those heart valves. And in certain cases, the patient's symptoms may be discordant or not agree with what the ultrasound shows, and kind of a tiebreaker is in order. And cardiac MRI is a great test for that because we can calculate the exact amount of blood flow that's going forward and backwards across the valve to a very accurate and reproducible extent.
And we can use those numbers to decide whether or not surgery is indicated at that point?
Correct, exactly. Or track it over time to see if it's really progressing.
Yeah, I do know that we talk about aortic valvular area in terms of valvular replacement or how much regurgitation there is before you start to think about replacing valves. So this is actually a more accurate way to perhaps measure the same things that we were measuring on ultrasound before.
Correct, exactly.
How about ischemic disease? In other words, the coronary arteriosclerosis, what people really think about when they think about heart attacks and heart disease. Has it been useful in diagnosing that at all?
So not as far as looking directly at the arteries, like a catheterization or CAT scan, but we can see the extent of scar or injury to the heart muscle, and we can see kind of the uptake of contrast in the heart muscle if there's a significant blockage at rest, restricting blood flow. It is possible to do stress tests with MRI that we're doing kind of at multiple centers across the world and even in the country. We haven't started doing these stress tests with MRI here at Nuvance yet, but it's certainly something that we're looking forward to starting in the near future.
And are you looking for, does the scar tissue have a specific signal on MRI, or are you just looking for a part of the heart that isn't moving?
Yeah, so scar in the heart, typically after we give the contrast, we wait probably maybe from 5 to 10 minutes and wait for that contrast to redistribute. And areas of the heart that are abnormal, whether it's something called fibrosis in the muscle or scar tissue, it becomes very enhanced or bright. And we see that on those last images we collect in the MRI.
You know, and again, to this contrast, this is very special contrast. It's not X-ray contrast. It's something that's designed specifically for MRIs.
Correct. So even if patients had a contrast allergy to iodinated contrast, or iodine or shellfish, there's no cross-reactivity with the MRI contrast.
Is this gadolinium? Is this the same contrast they use for tumors and things like that?
Correct, exactly.
Let me ask you the question that I know there's been some discussion about kidney damage with gadolinium, large volumes. Is that an issue with cardiac MRI at all?
So it's very similar to other studies. We typically give similar doses, if not a little bit higher. And the contrast that we're using generally is considered safe if your kidney function is adequate. We do have a strict cutoff that we use. If your kidney function is kind of below that, we tend to avoid this contrast agent. But generally, it wouldn't cause direct kidney injury. It's just if your kidney function is abnormal, it can cause some significant side effects.
And where do you see, we've got a couple of minutes left, less than 2 minutes, where do you see this field going over time?
So I see it continually advancing. The main things is decrease in acquisition time, new sequences to look at different tissue properties of the heart. You know, one thing that's applicable now that's really kind of making a resurgence is looking for myocarditis with the current kind of COVID pandemic right now. Mm-hmm. And there's a lot of controversy over who we scan, who we don't. But certainly we're getting kind of a lot of great information about that, patients that have kind of COVID inflammation in the heart.
And what do patients need to know? Is this something they should ask their doctors about, or is this something, you know, how does a patient get this? It sounds like patients with congestive heart failure, a lot of these patients with cardiomyopathy could benefit from understanding where this comes from. I guess particularly patients who have an undiagnosed cardiomyopathy?
Exactly. So, you know, if they go to their cardiologist and ask if they think they would benefit from a cardiac MRI, I think that's a very logical first step that they can easily do. Even if they go to their primary care doctor, if they're having certain symptoms, to then just, simply ask if an echocardiogram or an MRI is a good test for them.
And I guess last question, does this hurt in any way, having a cardiac MRI?
So you shouldn't feel anything. Sometimes the noise can be loud, but we put earplugs and have these earmuffs on or noise blockers. And you're lying straight, flat, but really it shouldn't be painful. Yeah,
well, it's a remarkable new technology. Stay tuned. There's just so much new that's coming down the pike. Unfortunately, we have run out of time. I really want to thank my guest today, Dr. Joseph Burdowski, for joining me on Health Talk today. Very interesting topic. Thank you for watching us. Remember to share your questions and comments by contacting us at healthtalk@nuvancehealth.org. We'll see you next time. Bye-bye.
145 over 92.
180 over 111.
182 over 100. And I had a heart attack and a cardiac arrest, and then a stroke.
Your blood pressure numbers could change your life.
A lot of people don't understand, including myself, I didn't, now I do, the impact of having a stroke.
My memory is shot.
When I woke up, I couldn't speak.
If I would have followed a treatment plan, I would not be in this situation.
It's a tough journey.
Lowering your high blood pressure could save you from a heart attack or stroke. If you've stopped your treatment plan, restart it or talk to your doctor about creating one that works better for you. Start taking the right steps at manageyourbp.org.
It's a new life, but I'm gonna make it better. Coming back. Ask your doctor, check your blood pressure.